screen shared.
It looks like Brian chatted in. He doesn't have a mic. He's the clinical pharmacist at OSU.
Perfect. Thanks, Dr. David.
Okay, can everybody see my screen?
Yes.
Okay. Perfect. Okay, so like Dr. Ladd said, today we are going to continue going through the different classes of antiretroviral therapies, and today we're going to go through the non-nucleoside reverse transcriptase inhibitors, or the NNRTIs. So relevant disclosures, I served as an advisory board member with Theratechnologies just last November, and then we also have a ViiV research study going on, to which I am the clinical pharmacist for that. And so neither of those should impact the discussion today, but they are my relevant disclosures. So learning objectives, kind of like with the nukes that we went through and the protease inhibitors that we went through, we're going to look at the NNRTIs. We're actually going to look at each of the individual NNRTIs. We're going to kind of discuss their place in therapy. None of them are preferred in the guidelines, so I'm going to kind of talk about where they've been historically, and then where the ones that we use now are placed. Talk about side effects, drug interactions, and then we'll talk about different administration requirements for each of them, because that does change with some of the NNRTIs. So just looking at our life cycle, NNRTIs and NRTIs both work on reverse transcriptase, and so that is here really the second step of the life cycle. So looking at the timeline, we looked at this timeline initially with the NRTIs. So looking at it with the NNRTIs in the 1980s, 81 was when AIDS was first identified within the US. If you remember from our NRTI lecture, we got our first NRTI in the late 80s, and then into the 80s and 90s, we got more NRTIs. It wasn't until the 1990s that we actually got our first NNRTI, and that was nevirapine in 1996, and then efavirenz in 1998. Our first fully active single tablet regimen was a triplet in 2006. And so that was a huge historical point for our patients, because a lot of patients were then able to go on a single tablet regimen, which prior to that, we weren't able to do. Now we think of it as it's just kind of what we do. Everybody gets a single tablet regimen. Everybody asks about single tablet regimen. Before 2006, they were on individual agents, often multiple times a day. And so 2006 is really what started the single tablet regimen. Etravivirine came to the market in 2008, and then in it's from 2011 up until our recent years, we have again a couple of more NNRTIs and then more single tablet regimens. So rilpivirine came out in 2011 with Complera as its single tablet regimen, Odefsey in 2016, Juluca in 2017, and then doravirine with its single tablet regimen of Delstrigo in 2018. And we'll talk about all of these. The blue, if it's in blue, going through the rest of this lecture, as you can see on the slide, that represents a combination single tablet regimen, just so we can keep everything straight. Since most of the NNRTIs are available in a single tablet regimen, I wanted to make it easy to kind of translate both ways. So nevirapine, no longer recommended, definitely no longer first line, no longer recommended. In fact, depending on which drug chart you look at, nevirapine is now relegated to the historical med section. And so you probably won't see it very often. I do bring it up though, because if you serve a refugee population, it is possible that patients will come in on nevirapine to you. I mean, we've had this happen multiple times with some of our refugee patients here in Tulsa. They come in on nevirapine, and generally speaking, we just switch them to something that fits in the modern therapy. But depending on what country they come from, nevirapine is still widely utilized in some countries. And so you may see it in on occasion. So just to be aware of it, the serious adverse toxicities in nevirapine and why it was kind of relegated to historical meds is hepatotoxicity, rash, including Stevens-Johnson's, and these can be very, very serious. specifically, you do not want to start nevirapine if you have a high CD4 count. And this goes against pretty much every other med and anything else that we've ever been taught. But if you have a high CD4 count, you are more likely to see those serious toxicities, hepatotoxicity specifically. There are gender differences. So if it is a man, you do not initiate it with a CD4 count above 400. And for a woman, you do not initiate it above 250. Once they're over those CD4 counts, if they're continuing on it, it's fine and it doesn't matter because we know that over time the CD4 count increases as long as they were initiated at those lower CD4 counts. So again, not something that you're going to see very often, if ever, but just kind of a fun historical drug to talk about, especially with the CD4 count requirements. So as I said earlier, efavirenz was our first co-formulated single tablet regimen. So it was co-formulated with the nucleosides tenofovir and emtricitabine as brand name Atripla. It was placed on the guidelines as first line for years and years. Currently it is under current clinical situations. Part of the reason it was moved to preferred in certain clinical situations is because of its adverse effect profile, which we'll get to in a minute. Efavirenz does have a lower barrier resistance to integrase inhibitors or the protease inhibitor class. And really, even among the nucleosides, it has a really low barrier to resistance. A single mutation of K103N can knock out efavirenz, and therefore Atripla is no longer a possibility. You do have a lot of drug interactions. It's the substrate of CYP3A4 and 2B6, and it actually induces 3A4. So 2 weeks ago, or last time, the holidays have thrown me off in the dates, but the last time we talked about protease inhibitors. Protease inhibitors inhibit 3A4. Efavirenz will induce 3A4. So you'll actually see a loss of efficacy of drugs at 3A4. There aren't very many that actually need dose adjustments, but it is something to be mindful of. So the reason efavirenz was moved from preferred is because of its adverse effect profile, specifically related to the CNS profile. And so worsening depression, including suicide ideation, was documented in at least one article and study. And so that kind of moved it from its preferred standing to just kind of the other category. Other common CNS effects are dizziness and vivid dreams. And if you've ever talked with a patient who's been on efavirenz, they will describe very vivid dreams to you. In fact, we've actually had problems getting patients off of efavirenz if we want to modernize their regimen because they want to continue because of the dreams. And so it's really interesting. It did cause some patients problems, including dizziness upon wakening, and some patients would describe it as they just felt drunk all the time. They also can cause severe dyslipidemia, specifically hypertriglyceridemia. I have seen some of the highest triglycerides of my career on efavirenz, and it does not respond to medication therapy. So, statins don't do anything. Your fenofibrates really don't do anything. The best way to treat it is to get them off of efavirenz. You can see rash. Triagenicity, so this was a big deal, especially when it first came out. In non-human primates, you saw neural tube defect issues within the first trimesters. That was never been duplicated within humans. And so the guidelines actually do say that you can use it in women. But again, I probably would avoid it. And it's worth knowing about that there has been that risk associated with non-human primates. And then counseling. So we actually recommend patients take it without food and at bedtime. And that is because of the CNS effects. Efavirenz will absorb appropriately without food, but it will actually absorb at a higher area under the curve concentration if you take it with food, specifically with a high-fat meal. And so we want patients to get appropriate absorption and not too much. So we tell them to take it without food. And then if we advise people to take it at bedtime so that they hopefully are sleeping through a lot of those CNS effects and the peaks of the dizziness and the drowsiness, etc. So rilpivirine is the next non-nuke that we're going to talk about. It is co-formulated in the following. So it's TDF emtricitabine, it is Complera. As TAF emtricitabine, it is brand name Odefsey. And then as the two-drug combination of rilpivirine and dolutegravir, it is Juluca. And so I'll kind of talk through each of these a little bit more individually. But again, substrate of 3A4, rilpivirine does require an acidic environment for absorption. So no matter how you're giving it, whether you're giving it as its individual self or you're giving it in a single tablet regimen, you cannot take this drug with a PPI or H2. Technically, if you read in the package insert, it talks about dosing an H2 at no more than 20 of famotidine daily. I discourage that mostly because I always worry about patients, accidentally taking more than 20 milligrams or taking it, you have to time it out 12 hours apart. So maybe the patient's taking it at the same time or not taking it at the right time. So I actually discourage it altogether. And if a patient really needs acid suppression reduction, to get them off of rilpivirine and get them onto something that will allow that. Fewer adverse effects compared with efavirenz. So you can see rash, you can see lipids, you can see CNS, but at a much, much lower rate than you see with efavirenz. So looking at kind of the individual combo products. So Complera-No-Def-C is rilpivirine with either TDF or TAF plus emtricitabine. So very similar there. You just have the TAF TDF difference that we talked about several weeks ago in our nucleoside. Complera-No-Def-C's place in a regimen is under certain clinical situations. And so we've used Complera-No-Def-C in a switch patient often if we want to get somebody off of a tripla who maybe they want to stay on the same class of medications. And so that's where we've used a lot of Complera-No-Def-C. We don't use it a lot in our clinic, mostly because it does require a meal, at least 390 calories for absorption. So it needs that acidic environment, but it also needs a meal. And many of our patients have nutritional problems getting appropriate food. And so I always am concerned about them being able to get enough food to absorb either of these combination products. The other note with Complera-No-Def-C specifically is you can't use it if their baseline viral load is over 100,000 or their CD4 count is under 200 because you'll end up with a chance of risking failure. And so we want to avoid that. So with Complera-No-Def-C specifically, if you're starting a new patient, not over 100,000 or a CD4 count less than 200. Okay. So Juluca is one of the newest drugs to come to the market. It is a 2-drug combination. Juluca is only approved for switch therapy. So it is rilpivirine plus dolutegravir, which is an integrase inhibitor. So we'll talk about our integrase inhibitors in a couple of weeks. So these two combined together are approved for switch therapy. So should not be initiated on a new patient, but can be used for switch. The FDA guidance for it is that it is to be used for viral load, patients who have a viral load undetectable for at least 6 months. Again, it does have to be taken with a meal and cannot be taken with anything that is acid suppressing. However, unlike Odefsey and Complera, there is no caloric requirement. It just has to be with a meal. It does have to be with a meal that you chew, cannot be like a protein shake or anything. The other note that I want to make here is that you cannot use it if you have an HBV positive patient. So if a patient has hepatitis B, you really shouldn't use Juluca because you don't have the appropriate hepatitis B treatment on board. You should use something with a 2 nucleosides in it. Okay, moving on to our last 2 nucleosides, etravirine is an older drug, and it originally had insufficient data on ART-naive patients, and so it started being used for salvage therapy among patients who had resistance. It does have a higher barrier to resistance compared to the other non-nucleosides. So even if you lose efavirenz or use rilpivirine, etravirine will still often work for a patient. It does have twice daily dosing. And so that can sometimes be problematic for patients. But again, usually etravirine is being used in patients that don't have a lot of other choices. Fortunately, as we've gotten more modern therapies, we have some other options available, but you may still see this on some patients. It is a substrate of 3A4, and so you have to worry about drug interactions there. And then finally, doravirine is the newest nucleoside on the market. It is co-formulated, available as Delstrigo with lamivudine and TDF, or it's Pifeltro by itself is the brand name. It got placed on the guidelines, I want to say a year and a half ago, as in certain clinical situations for naive patients. I think of it as a cleaner, less problematic efavirenz. So if I'm wanting to put somebody on a nucleoside and I don't want to have to deal with the food requirement for rilpivirine, and I don't want to have to deal with the CNS effects of efavirenz, doravirine is a good go-to. Is a substrate of 3A4, so it has less drug interactions than the others, and it doesn't require food to be taken. So it's a cleaner option if you're looking to put a patient on a nucleoside, especially if you're trying to avoid an integrase inhibitor for various reasons. So in summaries, NNRTI combinations are not first-line regimens, but they may be preferred in some patients, depending on what's going on with your patient and if they can't take other antiretroviral therapies. They do have a lower barrier of resistance as a class compared to protease or integrase inhibitors, and so something to think about if your patient has questionable compliance. There are various drug interactions and adverse effects across the class, and so just be aware of that as you're prescribing. And so that is my discussion for the day. Are there any questions?